we improve the outcomes of glaucoma filtering surgery. I think trabeculectomy is one of the commonly performed surgeries in eye, except for the cataract surgery, and everybody does the trabeculectomy. Though it appears very simple, but we all know that we can land up in problems many a times, and we have a lot of intraoperative challenges that we are faced with, and many a time we land up with a lot of post-operative complications also. So I would like to briefly run you through what are the steps that one can incorporate during the surgery to have better outcome of the trabeculectomy. All right. So I think what all our patients want after trabeculectomy is good vision with minimum medication and a comfortable eye. And what we all glaucoma surgeons aim for is a nice filtering bleb with good intraocular pressure control without any medication starting from 1 day post-operative to years beyond the surgery. And what we actually don't want is any kind of complications. And whenever we are talking about complications, mostly the side threatening complications like the suprachoroidal hemorrhage, the wipeout phenomenon, and in long term follow, we don't want leaking blebs or a bleb failure. And I think all of you would agree that the most important cause of all these complications is the hypotony, which happens during the surgery. And it's the suddenness of hypotony, the duration of hypotony, and the extent of hypotony, which is very important, which can land you up in these post-operative complications. So it is very important for all of us to identify the high-risk eyes which are more prone to develop these complications, especially the ones who have very advanced visual field defects and a macular split, or a very advanced glaucomatous cupping, because these are the patients who are more prone to develop post-operative complications. So I think a thorough preoperative assessment is something which is very, very important. We should know the eye that we are going to operate upon. And I think all of us want a pristine, untouched cornea, but many times we are dealing with secondary glaucomas, and we have scarred corneas, which can have scarred conjunctiva, which can have aggressive wound healing, which are thin and inflamed. So it is a good idea to check for the mobility of the conjunctiva with a wetted sponge before you're planning for the surgery. Now, again, these patients are on anti-glaucoma medication for a very, very long time, and we know that all of these cause a lot of blepharitis. So it's a good idea to put the patient on copious lubricating drops, give patient a drug holiday, and especially when we are talking about PG analogs, pilocarpine and Ripatec, it's a good idea to stop these drops 3 to 7 days prior to surgery, put the patient on anti-glaucoma medication. And sometimes if you feel that the surface is highly inflamed, it's a good idea to put the patient on some kind of low dose steroid 1 to 2 weeks prior to trabeculectomy. Now, again, we know that extreme degree of myopia or hyperopia can land you up in problems. So, if patient have high myopia, you can have thin and elastic flaps, and these can overfilter, and you can have bleb-related problems. On the other hand, hyperopes are more prone to develop aqueous misdirection and post-operative shallow AC. So, a meticulous suturing and a meticulous closure is required in high hyperope. So, you have to be careful in these cases. Now, once you have done a good ocular assessment, it's a good idea to know about the systemic control also. Do a good blood pressure control, and if the patient is on anticoagulants, stop the anticoagulants to avoid any kind of intraoperative bleeding, and it will also help you with post-operative suture lysis, or if you're planning for a suture removal, because if you have a large subconjunctival hemorrhage, then suture lysis will be very difficult. Now, again, diabetics we know have very high levels of anti-VEGF, and they have aggressive scarring. So it's a good idea to use anti-mitotic agents in these particular patients and be prepared what you are going to expect. Now, once you've planned the surgery, before surgery, it's a good idea to have a good intraocular pressure control. So always control the controllables. Operate upon a soft eye. What I do is to give preoperative mannitol 30 to 60 minutes before surgery. Do remember to give patient a bathroom break, because last thing you would like if patient is on the operating table and trying to pass urine and squeezing and straining, and you're not able to focus on the surgery. So give patient bathroom break, this is very important, and use as low volume of peribulbar anesthesia as possible. No super pinky is something which is very, very important, and use a lightweight speculum to avoid any kind of positive vitreous pressure. Now, the area where we are going to operate, you said you should have as maximum exposure as you want, especially if you're planning for a valve surgery. And now we all have shifted from a superior rectus traction suture to a corneal traction suture. But with corneal traction suture, also take care that you avoid any full thickness entry or too superficial an entry, because that can lead to cheese wiring. Again, avoid too big a bite, because that can lead to flap distortion and a difficult dissection. Now, handling conjunctiva is something which is very, very important. Conjunctiva is a sacred tissue for all glaucoma surgeons. So be gentle with the conjunctiva. Use plain forceps rather than a serrated forceps. Hold tenons as far as possible and use sponges. And try to make as sufficient peritomy as possible. Don't make too big a peritomy and too small also. It should be adequately sized. And as far as possible, avoid nasal bleb, because they are associated with frequent Dellen formation and can give rise to a lot of dysesthesia in the post-operative period. Now, younger patients often have thick tenons, so a complete dissection of tenons is important, because this can cause a lot of post-operative scarring and can also interfere with flap dissection. Intraoperatively, again, we have to take care that coagulate all the bleeders. Be gentle with your cautery. Don't over cautery. Don't use too lesser cautery, because you don't want a lot of bleeding also. But excessive cautery, we know that can lead to focal scleral thinning and bleb leak, so you have to be careful. And again, now antimetabolite and mitomycin has kind of become a routine for all glaucoma surgeries. So whenever we are applying antimetabolites, make the area as big as possible. Use multiple sponges. Take care that you're avoiding the edges of conjunctiva. Go as posterior as possible, and the time and the concentration of mitomycin can be dependent on the type of case that you are operating upon. And at the end, irrigate very nicely, so that you don't, especially if you're doing a combined surgery, that you don't leave any mitomycin in there. Now, Moorfield surgical technique has shown us beautifully that posterior flow is very important to have, to avoid overhanging blebs, which can create a lot of problems. And it's a good idea to leave 1 millimeter of sclera when you're making a scleral flap, so that you have as posterior flow as possible. Now, I think sclerostomy is the crux of trabeculectomy, and whenever we are doing a sclerostomy, it's a good idea that you place your side port before that. This is something which is very, very important. Pre-place your apical suture if you want. You should always release your traction suture whenever you are going in for sclerostomy. And one thing which is very important in order to avoid any kind of complications, that hypotony needs to be avoided. Now, this is the most important step, where you don't want to lose the anterior chamber and have hypotony, because if you have hypotony, there is immediate increase in the ciliary body volume, and patients can have shallow anterior chamber in the post-operative period. So it's a good idea to inject either air or BSS or viscoelastic, whatever you are comfortable with, from the side port before you are doing a sclerostomy. Now, again, you have to have an adequate size sclerostomy, and it should not be too anterior or too posterior. You can use vanas or Trifine, whatever you are comfortable with. And once you have done sclerostomy, you have to do an adequate sized peripheral iodotomy, so that you don't have any blockage of the sclerostomy opening. I'll just be quickly summing up. So once you have done the sclerostomy, we know that wound closure is something which is again very, very important. So I think TRAB, each and every step is important, and if you miss a step, you can land up in problems. So you have to be focused and paying attention to each and every step. We know that the blebs which are sealed well, they heal well and they swell well. And again, scleral flap suture, it's very, very important that you have a watertight wound closure. You can go in for either a releasable suture, or you can plan for a laser suturolysis later on. Check for the side port leakage, and if possible, repair them. Now, conjunctival closure again is very important. Depending on fornix or limbus based suture, you can use a Vicryl running suture, or you can put single interrupted sutures on the flap. Now, again, repair all the wounds intraoperatively only, especially if there's a buttonhole. And if you are in doubt, you can use fluorescent to check the wound leakage. Now, post-operatively, I think it's a good idea to put the patient on steroid, and slightly long-term steroids up to 3 months. That's what I do to prevent early bleb failures. And again, if you have done a releasable suture, you can go in for suturolysis, especially if the pressures are high starting from 1 week post-operatively, or do a laser suturolysis depending on what kind of suture you have placed. This is something which I usually teach all my patients is digital massage, which is described as Carlo Traverso maneuver, in which patients are taught to do gentle massage on the in the eye, on the globe, especially on the area opposite to the bleb, so that the bleb continues to be there and continues to function nicely. And I've seen that this shows good results in maintaining the successful outcome of trabeculectomy. So I think each and every step is important, and you have to do careful pre-planning, make tailor-made decision, as we know that every patient is unique, and give every patient a diligent post-operative care. Thank you so much.